From the research bench to the patient's bedside, this is Bench to Bedside with your host, Vice Chancellor and Director of the University of Kansas Cancer Center, Dr. Roy Jensen.
Good morning. I'm Dr. Roy Jensen, Vice Chancellor and Director of the University of Kansas Cancer Center. Genes are pieces of DNA that are passed down from parents to children. Between 5 and 10% of all cancer cases occur because of an inherited genetic mutation. Dr. Lauren Nye and Dr. Jennifer Klemp are here to talk about genetic testing in ways that may help answer your questions and determine a path forward for you. Becky Burns, I just gave you a promotion there, or maybe a demotion, I don't know. Is also with us today. Becky Burns is a member of our patient research advocacy program, PIVOT. That is definitely a promotion. PIVOT connects our cancer survivors with our investigators to ensure our research is patient-centered. I'm going to start with you, Dr. Klemp. What is a genetic test?
So I think it's important to kind of understand that there's actually two kinds of genetic tests. So you talked about the type that's inherited, but some of our patients who have cancer actually also get their tumors tested. But today we're talking about the inherited, or what you would get from your mom or dad. So we kind of like to talk about it as kind of a misspelling of a word. And when your word is misspelled, it can lead to changes in your body where we no longer are getting the positive effect of that change, but it can lead to an increased risk of cancer. And in particular, for inherited cancers, that could include breast, ovarian, colon, pancreatic, prostate, melanoma, and really that's expanding. So this is a test that looks at the spelling of your DNA to find an error and to help us really interpret what the risk is, and then some additional pieces as well, which we'll talk about.
Okay. So, Dr. Klemp, tell us a little bit more about some of these specific mutations and how they can influence your health.
So there's a lot of acceleration that's happened in genetic testing. And I like to kind of talk back to the very first test we sent in for breast cancer here was in 1997. And it was a very different world in genetics because we were only looking for two genes, BRCA1 and 2. You had to draw it from a tube of blood, and it went to a laboratory, and there's still specialty laboratories where these tests go. But it would take 4 weeks, 6 weeks, 8 weeks. Now, genetic testing can be a blood sample, or you can spit in a tube. It can be back in as little as sometimes 5 days or less. And we're not just looking for two genes, but we're often looking for multiple genes. And I think one of the most important things about looking for multiple genes is you only know what you know. So if we only looked for BRCA1 and 2, then we would only find changes or those misspellings on those two genes. But now that we look for lots of genes, we're able to see that this breast patient actually has a colon cancer gene, and we're able to really manage that patient a lot more effectively.
Mm-hmm. So, Becky, I'm going to turn to you now. You are a breast cancer survivor, but before your diagnosis, you underwent genetic testing. What did you find out from your genetic test?
So, when my cousin was diagnosed with breast cancer, she came to me and she persuaded me to get tested for the genetic mutation that she found out she had. So when I got my genetic test results back, it did show that it was positive for a known pathogenic mutation, and it was the family mutation that in our BRCA1 gene. It also said that I had an increased risk for breast cancer and other BRCA1 related cancers, and it suggested that I see a genetic counselor and that I persuade other possible at-risk members of my family to see a genetic counselor.
So when your cousin came to you with this request, could you tell us a little bit about the concerns that you had over genetic testing at the time? And what year was this, by the way?
That's a good question. It was 2015, so it's been a while. But I kind of went around it backwards a little bit. I saw my regular doctor instead of going to a genetic counselor first. which in hindsight, I wish I would have done because I didn't have any questions answered ahead of time. So I was worried about, what would a positive test result mean for me? At the time, Angelina Jolie coming out with her diagnosis and surgeries was big. And so I was worried that, does that mean that I would have to have all these surgeries? I was also worried about insurance, whether insurance would cover the testing. I know the doctor's office said that it would, but I was worried that I would get a bill in the mail and that it would cost me a lot. I also worried about life insurance, that if I got a positive test result, that it would impact my ability to get life insurance later on. And then ultimately I worried about whether, if it was positive, if I could pass it on to my daughter, who at the time was only 3 years old.
So not only, as you say, were you found to be positive for this mutation, then that prompted a whole nother workup. And could you tell us a little bit about that?
Sure. So once my doctor found out that my results came back positive, she sent me to KU Cancer Center, to the Breast Cancer Prevention Center. And I met with Dr. Fabian and her team, and she looked over my results and explained them to me and told me that I had about approximately 70% risk of getting breast cancer in my lifetime. And we came up with a plan that I would have surgery for a hysterectomy, and then we would do mammogram and ultrasounds, and then also MRIs, and we would alternate every 6 months. So she sent me automatically out right away to get a mammogram and an ultrasound. And when the results came back in, they found a mass, and it turned out that I had stage 1A breast cancer that was hormone positive. So stage 1A, if you don't know, is pretty, has a good prognosis. We caught it really early on, which turned out to be a good thing, obviously. And so the test really kind of saved my life, I believe.
Absolutely. So it may have been uncomfortable when your cousin came to you, but that turned out to be one of the best things that ever happened. So I want to turn now to Dr. Nye. Tell us, should every woman who gets a diagnosis of breast cancer get tested for genetic mutations?
That's a great question and really controversial in the oncology space right now. I think in the ideal world, absolutely, yes. As Becky explained beautifully, it can inform so many things. I don't think I could have laid it out better in all the ways that can inform care, from screening and options to family testing. But right now, I think we're trying to prioritize who is at highest risk of being found to have a mutation based on family history or the type of cancer diagnosed, and who needs that testing to inform treatment options.
Okay. So let's say, Becky, I decide to get genetic testing for some reason, and I find out that I'm carrying a mutation that increases my risk of developing a specific type of cancer. What is the next step in that patient's journey?
Breathe. That's where I start. Exhale. And then again, like Becky said, the first step is getting that post-test counseling, whether that's with an informed provider or a certified genetic counselor. You need to understand what that mutation means for you personally. So that means understanding what is the risk of cancer and which cancers. What are your options for screening? What are your options for risk reduction? There's this wonderful image I love from the U.S. Army Corps that talks about risk communication, and that involves understanding what your risk is and understanding the management options you have to address that risk, and then inputting your preferences and values to come up with your personalized plan. And that's the goal with genetic testing, not to say you have this mutation, you're going to surgery for X, Y, and Z, but let's come up with your personal plan for managing this.
And what would your preference be in regards to when that individual should get that genetic counseling, before or after the test?
I think it depends on the situation. I don't think we have enough certified genetic counselors in the U.S. or in the world to take care of all the individuals that meet criteria for genetic testing. So we really worked on identifying those patients that what we call need point of service testing, that are already set up with somebody well informed on genetics that can at least get them through the first steps of ordering the test. And then we still have our genetic counselors for that post-test counseling, and it allows them to elevate to the level of performance that they can and talk through these really complicated cases. But for some patients, that upfront genetic counseling is really important as well to answer a lot of the questions that Becky had, because they're all real risks and concerns with genetic testing.
So if you're just joining us, we're here with Dr. Lauren Nye, Dr. Jennifer Klemp, and Becky Burns talking about your genes and your cancer risk. So many of us have lost family members to cancer, and so we might be wondering if our genetic makeup puts us at greater risk for developing the same disease. Remember to share this link with people you think might benefit from our discussion. Use the hashtag #BenchToBedside. Now, we've talked about the importance of genetic testing, but not everyone has access to this type of specialist. And the two of you have really, I think, come up with an important way to increase access. And could you tell us a little bit about the important study that the two of you led to do just that? And we'll start with you, Dr. Klemp.
Sure. So I think that Dr. Nye and I have had the great fortune of having a shared passion of increasing access to point of service testing for both patients who are at high risk, so don't have a diagnosis of cancer, and for those who have a diagnosis. So those who have a diagnosis, I think that's sometimes a little easier because they already have a cancer provider. Maybe they're seeing, they're seen in a cancer center, but there's a lot of individuals who are living in our communities and they're maybe seeking primary care when they have a cold. So how are the rest of the individuals out there getting risk assessment? So we've been able to get some funding actually by the Susan G. Komen Foundation to allow us to do a project, which I'll have Dr. Nye go into a little more, but it's working with providers who do well person care and working through some of the state and federal programs so that we can increase access not only by collecting information using technology, but being able to provide them with some of the tools at that point of service to do risk stratified care. So as you can imagine, if you have a patient and you're saying, well, you shouldn't get a mammogram till you're 50, but they really have a higher risk, and maybe they have a really high risk because they have a gene mutation, if you don't know that as a provider, it puts you in kind of an uncomfortable position because you're ordering screening, but are you really comfortable with the risk of that patient?
Right.
So I'll tee it over to Dr. Nye to complete, telling a little more about the story.
Yeah, I think the key is we're trying to put the information that's needed in the hands of the patient's trusted provider. So in the hands of who they're already seeking care from, so that provider can go ahead and perform a genetic risk assessment, meaning they can look at their family history and determine, do they meet criteria for genetic testing? And even if they're not comfortable providing genetic counseling, that's the first step to getting that patient referred to a genetic counselor that is frequently missed. And then Dr. Klemp and I hone in all the time that a negative genetic test does not mean low risk of cancer, and there's many women out there with negative genetic testing that are still at an increased risk of cancer and can benefit from that high risk screening, such as mammography and breast MRI that can lead to early detection.
Mm-hmm. And I do think that building on that trusted provider, one of the things that's really challenging when you do outreach is if you don't have that circle of care, a lot of patients will fall off. And so by having a trusted provider, regardless of where that clinic is, that's where we believe that you can really provide that comprehensive or circle of care to the patient.
I know that this project happened in the thick of COVID, which obviously had a tremendous impact on really everything we've done. And we also know that cancer screenings took a huge hit during that time, in part because of our own Ron Chen's work. Did the same thing happen for genetic testing, Dr. Nye?
I think that's a great question. It's not answered specifically in the literature, but we would assume yes, that care delivery across the continuum decreased during the pandemic. However, I think this is one of the highlights or positives of the pandemic is almost overnight we saw everybody turn to telegenetic counseling. So now patients had access to genetic counseling right from their home on their computers. And we also saw the genetic testing companies rise to the occasion. They would now overnight ship a kit to a patient's home so they could do genetic testing from the comfort of their home. So really within, I would say, a week, we were able to pick up and continue genetic testing even when those patients weren't able to come to our clinic.
And I think the other piece that COVID accelerated, and for some of us, we've been doing telegenetics for years because Kansas, we're a very, rural state. But we saw families where, like Becky or like Becky's cousin would say, you know what, I'm going to pull together all my family members. So I had sessions with sometimes 8 different locations of patients where you're providing just the basic education and information. So I think that was really a lot more accepted by family members, where they could all be seen sort of together for shared visits, not talking about their individual situations, but that really has become, I think, a lot more comfortable for patients too.
Right. Yep. So Becky, as a member of Pivot, you frequently partner with a number of our researchers here to help ensure that they have the patient perspective. What has this experience taught you about research and your own particular situation?
Well, when I was diagnosed with breast cancer and after I went through treatment and I was all done, I wanted to have a way to use my experience to help others. And Pivot was one way that that gave me a way to do this by using my experience and help researchers. So we have something called a rapid reactor panel where researchers come in and they present their research and they always have a question for us. And at the end, we give our opinions and things like some of the things that we can help them with is how to express their research in a way that makes sense to patients. So for their clinical trials, they're going to need to get patients in. And so it's better for the patients to be able to understand in layman's terms what their research is looking for. Also, we can help out by telling them whether something in their research is going to be a burden on the patient and maybe give options and ideas of what patients would actually be more willing to tolerate, as well as ideas for how to bring more patients into research, their research study. One researcher that I was actually paired with, his research was on studying how like genes like BRCA1 and 2, and there's others as well, how they actually work to help our body fight off cancer. And learning this would actually help find out ways to maybe prevent the mutations or cure the cancer and things like that. So that was really interesting for me.
Mm-hmm. So we're approaching the end of today's episode, and I have one more question for each of you, and I'll start with you, Dr. Klemp. What do you hope to accomplish in your research program over the next decade?
So I think over the next decade, I tend to always be this, I'm not saying a visionary, but I'm often 5 years too soon. So my journey to democratize genetics has always been my passion. So we need to bring sort of an expectation that genetics is part of every patient that walks in our door, whether they have cancer or not. It's going to inform us how to care for that high-risk patient. So testing is going to be part of what we do for every patient. So that's what I believe will be the kind of the core of my research. And part of what we need to do then is help providers, organizations, insurance companies, patients, everyone who's a stakeholder really understand that process. How do we kind of update that process and make it more mainstream? And how do we make it kind of a standard part of care? Mm-hmm. So that's what I'll be focusing on over the next decade.
Sounds good. Dr. Nye, your turn.
And I would say my response is similar in that I want to see not just genetic risk assessment, but cancer risk assessment and management get to every individual that needs it, when they need it, and for that to be effective, efficient, and equitable.
And Becky, first of all, I want to thank you for sharing your story. It's a very powerful one and offers some great lessons to many of our patients. I guess I would start off by saying, some people might be hesitant to undergo genetic testing, say when their cousin comes to them, and as the saying goes, they don't want to borrow trouble. What would you say to someone who has these concerns?
First off, the first thing I think of is knowledge is power. If we know something, then we can do something about it. But I do get where people are coming from, that it is scary and we all have busy lives and it's just an extra thing. Sometimes it feels like for us to do. But in my case, like I said, I would not have found out that I had cancer, and my prognosis could have been much worse. And also finding out about my diagnosis, my cousin and I were able to talk to another cousin and have her, we persuaded her to get tested, and she ended up being positive, but she's able to then manage her health in a better way since she knew she had the results. So again, knowledge is power.
Absolutely. So Dr. Nye, Dr. Klemp, and Becky, thank you for being part of this week's episode of Bench to Bedside. To learn more about genetic testing, visit kucancercenter.org/genetic testing. That's it for today. Join us next week at 10 a.m. for Bench to Bedside. Thanks for watching. Subscribe to our Bench to Bedside podcast, now everywhere podcasts are available.